Last at 9 we would start. It's 8:59 now. So it's 9 p.m. Hello, everybody. We are here for our next edition of Neonatal Super Specialty Clinic, also known as Neo Music. And today we have our moderator, Dr. Kirti M. Naranje, who is additional professor and head Department of Neonatology at SGPGI Lucknow. And we are very happy to have you, Dr. Kirti. She runs the Indian course of the Brain Symposium very successfully, and we have very frequent lectures on that. So she is expert in neonatal neurology, with that being her area of interest, we can say. So, Dr. Kirti, welcome.
Thank you, sir.
Would you like to introduce our speaker, Dr. Atin Kumar?
Sure, sir. So, hello everyone, and welcome to the today's new music webinar on neonatal radiology, basics of CT and MRI. And today we are having Professor Atin Kumar, sir, who is a professor in radiology at All India Institute of Medical Sciences, New Delhi. And he is will be teaching us on the basics of CT and MRI, which we often do in neonatal age group, and often are confused about how to read about it and how to interpret the findings. So, welcome, sir, and over to you for the interesting session.
Thank you so much for this kind introduction, and thank you to Dr. Amit and the entire team of National Neonatology Forum for this opportunity to me. So, okay. Right. So, everything is fine, I guess. So, let's go along. In this next around 50-55 minutes or so, or maybe I'll see if I overshoot the time also. I will try and address the basics of CT and MR. I'll not go into physics, but I'll at least go into the practical considerations which are required for our day-to-day practice, the basics of what we and how we see on CT and MR, and I will then include multiple cases of our common pathologies or common conditions, and then we'll see about discussing their imaging features. So this is what I've already told you. Okay. Basic principles of CT. What we should know is that CT is basically dependent upon radiation modality. It is using the X-rays. It depends upon how much amount of X-rays are absorbed in a tissue, and then they cast what you want to call it a shadow on the detectors. CT is a cross-sectional imaging, so you can have a cross-sectional imaging of the body, and depending upon how much the various tissues in the body attenuate the different X-rays, they lead on to what we call as image attenuation of those different parts. So I'll show you by examples. When we're talking about the brain, this is what a normal CT imaging of the brain looks like. These are the axial cross-sectional CT scan images, and we're going up. These are cross sections, let's say around 5 to 10 mm apart. This is from the base of the skull. Then we are going up cranially till the almost the level of the vortex. As you can see, this white part or the bright part is the bone which we see, and bone appears quite hyperdense on CT scan examination. Whereas the ventricles, they contain the CSF, and CSF is fluid. Fluid, as you can see, appears absolutely hypodense. Hypo means less, dense means less density. Hyperdense is bright density. The fluid absolutely on the other end of the bone appears absolutely hypodense. What is more hypodense than even fluid is air. So air appears even darker than fluid. How do you see air? Where do you see air in the brain? You can see air either in the mastoid air cells or in the paranasal sinuses. So if you see this air density, which is absolutely dark or on CT scan images, is even darker than the fluid, which is slightly brighter than air, but still hypodense. In terms of absolute measurement, if we measure the Hounsfield unit of this, Hounsfield unit is the basic density unit which we can measure on any CT scan image on the console itself. You cannot measure it on the film, but you can measure it on console. If you measure the Hounsfield unit, air Hounsfield unit is in negative. Air Hounsfield unit is like minus 1000, minus 900, minus 800. Whereas higher than that, the Hounsfield unit is of fat, which is around minus 100 to minus 50. Even higher than that is of fluid. Fluid is around 0 to 10 or 20 Hounsfield units. Then higher density than fluid is a soft tissue density. So brain has soft tissue density. Brain, in which you can see there is a density of white matter and there is density of gray matter. We know that this is the peripheral gray matter or the cortex, and this is the white matter. As you can see, the white matter appears slightly more darker compared to the gray matter. The gray matter is absolutely bright. The white matter is appearing hypodense compared to the gray matter. And therefore, we can differentiate the gray matter from the white matter. And we call this appearance as a gray white matter differentiation. We can very clearly see the gray white matter differentiation here in these areas. What are these? These are sulcal spaces. We are seeing sulcal spaces that's hypodense because sulcal spaces contain fluid, which is the CSF actually. And CSF is fluid, fluid is dark, so CSF containing sulcal spaces appear dark. So on a normal CT scan image, you can see CSF in the cisterns, which is like the supracellular cistern here, the MCA cistern here, the cisterns around the brainstem, ambient cistern here, in the ventricles. These are the lateral ventricles. This is the fourth ventricle. And you can see CSF in the sulcal spaces. Then you can see CSF along the falx. This is the falx interhemispheric fissure. This is the white matter. This is the gray matter. And that's the normal appearance of the brain on CT scan images. Please remember that I am using the word density when I'm talking about CT scan images. We use the word density to look for attenuation. When I will be using the term, when I'll be seeing the MR images, I will correspondingly use the word intensity. So we do not use the word density in MRI, but we use the word intensity. So if it is bright, we call it hyper intense. If it is dark, we call it hypo intense. And if it is ISO, we call it ISO intense. Similarly, I'm sure you guys know that in ultrasound, we use the words echogenicity or echoic. We call it hyperechoic, hypoechoic, or anechoic or isoechoic, right? Once we give contrast, what is contrast? Just a sec, please. Actually, I think someone needs to mute their audio. I'm getting some disturbance. And my request for everyone else to please be on mute, actually. Thank you. Okay. Sometimes we need the help of giving contrast. What is contrast? Contrast, as you can see by English, is actually something which gives a contrasting density. On layman terms, we call it a dye, which we give. When we give an agent, which is an iodine containing agent, when we use in CT scan, it actually goes into the vessels and then it leaks out into the tissues and it appears bright on CT scan images, that is appears hyperdense. So contrast is something which brightens up the image. Like this was a plain CT scan image, but once I have given contrast, intravascular contrast, you see the contrast is seen as hyperdense. It is something which is appearing bright, and I can see the vessels enhancing with contrast. So I normally see contrast within the vessels. This is the sinuses in which I see contrast. These are the arteries in which I see contrast. The contrast can also cross the blood-brain barrier in cases when there is a blood-brain barrier breach and then can leak out into the tissues where I can see contrast. So what all tissues can show contrast? Whenever there is leak in the blood-brain barrier. That can happen when there is inflammation at the level of the meninges. So whenever there is infection or inflammation, we can use contrast, because then contrast will leak into the tissues and we can see contrast enhancement. Or in cases of tumors, tumors also lead to a blood-brain barrier breach and can show contrast enhancement. So this is a contrast image. This is a plain CT scan image. How do you identify? You do not see any hyperdensity in the vessels or in the venous sinuses. This is a plain image. But when you see hyperdensity within the vessels or in the venous sinuses, you know you are looking at a contrast image. Okay. Let's look at some examples. This is a contrast CT or a plain CT. This is actually a plain CT because I do not see contrast density within the vessels, within the sulcal spaces. But I see some hyperdensity within the ventricles here. We have learned till now that the ventricles will appear hypodense on CT scan because they contain CSF, but here the ventricles appear hyperdense. So, and in this particular case, which is a different patient, there is hyperdensity within the brain parenchyma, specifically in the white matter in the right frontal lobe. So this comes to a new teaching point. What appears hyperdense on CT scan images? We know that bone appears hyperdense, but we know that there cannot be bone inside the brain. We know that contrast appears hyperdense, but I'm telling you this is a plain scan. We've not given contrast. So what else appears hyperdense on CT scan? The most common two things which appear hyperdense on CT scan are blood products or calcification. So when you see hyperdensity like this is either blood or calcification. Now, by our experience and by our knowledge, we can tell whether this is blood or calcification. There cannot be a large area of calcification like this in the brain. It's more likely to be bleed. So this is bleed. And again, this is bleed within the ventricle. It is taking the shape of the ventricle. There is bleed in the right lateral ventricle frontal horn, bleed in the left lateral ventricle, and some bleed along the falx. This is a parenchymal bleed. This is blood. So this is hemorrhage. Moreover, if you have doubt between blood and calcification, you can measure the HU, the Hounsfield unit of the blood. Typically, blood has a Hounsfield unit of around 60, 70, 80 Hounsfield units, whereas calcification is even brighter than the blood typically and has a Hounsfield unit even more than that, around 150, 200, or even more than that. Okay, let's see another example. In this case, you see that there is hyperdensity within the sulcal spaces in the brain parenchyma, in the brain. So if I tell you this is a non-contrast CT, then you know that sulcal spaces here should contain CSF, which was supposed to be dark, but now you see hyperdensity. So again, this is blood, but now blood in the subarachnoid spaces. So with which I can detect bleed. So this is intraventricular bleed, this is subarachnoid bleed, and this is intraparenchymal bleed. Okay. Another example. Again, I'm seeing cisterns. I can see blood in the cisterns. So this is intra. So this is subarachnoid hemorrhage. And also I can see hyperdensity within the sulcal spaces. So this is blood within the sulcal spaces. Again, subarachnoid hemorrhage. What's happening also because of the blood here, there is some mass effect and edema. There is sulcal effacement and there is some mass effect over the left lateral ventricle. You can see the right frontal horn of the lateral ventricle is well seen, but the left lateral ventricle frontal horn is getting compressed. That is because there is mass effect because of the subarachnoid space bleed here in the left side. Okay, let's compare this to this patient CT scan. In this patient also, there is hyperdensity within the sulcal spaces seen along the basal cisterns here, along the MCA cistern, as well as along the cisterns along the brainstem. So this is the ambient cistern, this is the prepontine cistern. But what else I can see here? That there are some other areas of hyperdensity also, which is seen in the brain parenchyma, also along some sulcal spaces, and also if you see that there is hyperdensity within the venous sinus also. In this, you can see there is no hyperdensity in the venous sinus, but here you can see hyperdensity in the venous sinus. So either this is bleed, or actually I can see and tell that this is actually not bleed, but this is a contrast enhanced CT scan which has been done. This was a plain CT scan. This is the contrast CT scan. I can see actually the multiple vessels here. If on the contrast CT scan I see hyper density here, then instead of blood, I will call it as that there is a hyper enhancement in the sulcal spaces. When there is hyper enhancement in the sulcal spaces, it means that there is contrast leaking out into the subarachnoid space, which means that there is inflammation at the blood-brain barrier, and which means that there is meningitis. So this is basically meningitis, or these are actually exudates in the basal system. This was a slightly older child, but I'm just showing you how contrast density also appears and mimics the density of the blood. So you need to know whether you've performed the plain CT scan, then it is blood only. But if you've done a contrast and then only you see this hyperdensity, then it is more likely to be actually contrast enhancement. Just a quick example of how pathology in the brain looks like. Most of the pathology in the brain, if it is not bleed, bleed is bright, bleed is hyperdense, but rest of the pathology is appearing dark on CT scan, that is hypodense. So if you see area which is hypodense here, God has given us two sides of the brain which are absolutely symmetrical. So you compare to the other side, then if there is asymmetry, you know there is some area of abnormality, even if you're not able to pick up earlier. You know that there is some abnormal hyperdensity here in the brain parenchyma in this particular case. This was infarct. Another area in this, there is a hypodensity on the right side, so there is an infarct on the right side. And if you do a MR angiography is nothing but evaluation of the vessels of the brain. We have done a MR arteriogram. We can see this is the ICA which is getting occluded here. So the right MC is not visualized and there is a right MC territory infarct. Another example, a large hypodensity seen in the right, the posterior temporal lobe. In this case, if you see, this is involving only the white matter. The gray matter is spared. In this case, it was involving both gray and white matter. This was more likely to be infarct, but when only white matter is involved, this is more likely to be edema in the white matter. Another example, again, you can see abnormal hypodensity here. This is the ventricle. This is abnormal hypodensity here again. So edema in the white matter here. And another example in which you can see bilateral, almost symmetrical hypodensity in the white matter on the CT scan. This is the normal appearance of the white matter, but if you see, you can definitely see. So even if it is symmetrical, because this rule of asymmetry does not always apply, sometimes things can be symmetrical, but then you can compare to the posterior part and you can see that there is abnormal hypodensity here. This was actually an early onset leukodystrophy, but we'll not go into details of that, but this is just to make your eyes visualize that there is abnormal hypodensity here, right? Let's go to some other examples. See, this is some plain CT scan, but there is some area of abnormal bright areas which are seen where anatomically this is the location of the globus pallidus and some location of the putamen also. So there is hyperdensity. As I told you earlier, hyperdensity can either be due to bleed or contrast or calcification. So which of them is this? Can there be bilateral symmetrical enhancement because of contrast in the basal ganglia? There could be lesions, but that is unusual. And moreover, I do not see contrast in the sinus. So this is a plain CT scan. So this contrast density is ruled out. Can this be blood? Of course, this can be blood. If I measure the HU value, then I can try and differentiate between calcification and blood. However, let's be more practical. Even if it's just a film which is given to us without the HU value, I know there is very, very less likely that there can be bilateral symmetrical appearing bleeds in the basal ganglia. So that is unlikely. So what it leaves us is that this is likely to be bilateral symmetrical calcification in the basal ganglia. We know that basal ganglia is one of the common areas to get calcification, and calcification can be bilateral symmetrical, especially in the when it is happening in the region of the globus pallidus or the putamen. Let's see another example. This was almost a few month old child. You can see that there is some abnormal area of hypodensity in the white matter. This is the ventricle. The white matter appears slightly abnormal hypodense here. But what I'm trying to show you is there is some abnormal hyperdensity at the margins of the lateral ventricles here, right? You can identify that this is abnormal hyperdensity. So is this blood or is this calcification? If it was intraventricular blood, it would not be at the margin. It would be present within the ventricles, but this is not within the ventricles. This is at the wall of the ventricles. So it cannot be blood, but instead it is calcification. It is hyperdense. So calcification at the ventricular margins with some abnormal white matter density. And if you carefully see that the gray matter here is appearing slightly smooth. It does not show proper sulcal spaces. So this is a polymicrogyria or a pachygyria type of a pattern. A combination of these findings a pachygyria, polymicrogyria, white matter hyperdensity, as well as periventricular calcification is a classical marker for congenital congenital CMV infection. Can be seen very early in the neonatal period or at least in the early childhood period. Okay, let's see some more examples. A CT scan image. In this, there is some abnormal hyperdensity seen as a almost as a ring rounded structure on the right parietal lobe. There is nothing here, so this is not a normal thing. Is this contrast or is this plane scan? This is of course a contrast scan. I can see contrast density, hyperdensity within the venous sinus. So this is a contrast enhancing, a ring enhancing lesion. I'm just trying, this may not be a neonatal image, but I'm just trying to show how a contrast density lesions appear. It may be a tumor or there may be a bigger list of a ring enhancing lesions, can range from most commonly infections, which can range from fungal infections to abscesses to neurocysticerci to tuberculomas to miliary lesions to metastasis to even tumors also they can be seen. Another example, again you can see a peripheral hyperdense. This is again a contrast CT, so you would call it a ring enhancing lesion with abnormal hypodensity in the white matter here on the CT scan. So ring enhancing lesion with perilesional edema. That's the most common thing. Another ring enhancing lesion with perilesional edema. This is just to show you that how a contrast density enhancing lesions within the brain parenchyma appear like. So with this, let's go to some basics of MRI brain. CT scan was simple. There is only one type of image you can get, which is in which the gray matter is brighter, the white matter is darker, the fluid is black or hypodense, the bone is bright or hyperdense. But when it comes to MRI brain, the things get complicated because in MRI we do not have just one single type of a image, but we have different types of sequences which we do. I'm sure you must have know that we can do either a T1 weighted sequence or a T2 weighted sequence, or then otherwise combination of these sequences. Sometimes we call it susceptibility weighted sequence, diffusion weighted imaging, flare imaging, inversion recovery imaging. We'll see some of those examples, but will not confuse you, but will stick with the conventional imaging, which is the T1 and the T2 weighted imaging. What does MRI involve in terms of physics? MRI does not take into account any radiation. So X-rays involve radiation, CT scans involve radiation, the same radiation, but in a different strength with a different physics, different detector. But in MRI, there is no radiation at all. It depends upon a strong magnetic field which we give. When we place a human body in a magnetic field, in a very strong magnetic field, the protons in the body get aligned themselves according to the magnetic field because of their paramagnetic properties. Once we give a pulse, they de-align against the magnetic field, and when we remove a pulse, they come back to their normal state and they release energy. That energy we measure and we produce it into a digital format, and therefore we get various types of images. The crunch of the thing is, since it does not involve any radiation, so it does not have any harmful effects on the patient. CT scan is actually harmful, especially for a child. It is actually harmful. So we need to use it very judiciously. It's not to say that one CT scan can lead to significant harmful effects, but if not used judiciously, if used multiple times over and over again, a cumulative radiation dose can lead to harmful effects in the child or even in an adult. Whereas if you do MRI, it does not have any side effects practically, especially if you're not using contrast. The only disadvantage of using MRI is MRI actually requires time to get those images. CT scanners, we currently have so fast CT scanners that we can produce an image of the brain in 1 second flat. But practically, we do a imaging of the brain in 5 to 6 seconds or maximum 7 to 8 seconds. What is the advantage of this is you do not get motion artifacts, especially in the cases of children. If we subject them to CT scan, if they move over a period of time, you are likely to have motion artifacts and the images will not be of good quality. However, if the scan is finishing in 4 or 5 seconds, there is less likelihood of the patient moving in that 4 seconds and you can get a CT scan done immediately. But with MRI at least minimum to minimum requires 10 to 15 minutes, even if you're doing a very fast MR, but practically will require 20 to 25 minutes, and you want to lie the baby to lie still to acquire those images. So the challenge comes to sedate the baby or to give the GA. So therefore, MRI has to be used judiciously. I know that in neonatal age group, we can actually get a MRI done without these techniques of sedation or GA by just getting either milk feeding the baby and then letting him or her go off to sleep and then trying the MRI. That we can always try and get it done. But then it is best done with a good coordination between the neonatologist who's getting the child to get a MRI done and the radiologist. Of course, there are disadvantages that the child has to go in the tunnel in the MRI. If you have to put the monitoring units, they are more cumbersome as compared to CT scan, and of course, not so much for neonates, but for older children and adults, there is a issue for claustrophobia also. When you acquire MR images, you acquire multiple sequences, as I've told you. We conventionally acquire most commonly T1 and T2 weighted sequences. So let's try and see how do we identify a T1 weighted sequence. Both of these are T1 weighted sequence of the brain. There is a difference between the two in terms of the age of the patient. This is how a T1 weighted sequence appears in a neonatal age group. This is how a T1 weighted sequence appears in a child or any adult more than 2 years of age. Why is there a difference between these two images? Because both are T1 weighted image. It's because of myelination of white matter. White matter myelination, we all know, progresses over age. Actually, we all now know with our good research and experience that white matter myelination continues in even adult age also. However, practically speaking, most of the myelination gets completed by 2 years of age over a period of 2 years of age. So the unmyelinated white matter, since it contains a lot of water content and less of lipid content, water content is there in the unmyelinated white matter. Let's see how water appears on T1 weighted image. This is fluid in the ventricles. This is a T1 weighted image. The fluid in the ventricles on a T1 weighted image appears hypo-intense. That is dark on a T1 weighted image. Where all do you expect to see fluid in the brain? You see fluid in the ventricles, you see fluid in the sulcal spaces. So look at the sulcal spaces, look at the ventricles. If they are appearing dark, it is practically a T1 weighted image. Let's consider it as a T1 weighted image for all practical purposes, right? So this is something which was same like a CT scan image, because remember on a CT scan image also the fluid was appearing hypodense. So a T1 weighted image mimics or parallels like a CT scan image. Even the cortex appears bright and the white matter appears slightly dark as you were seeing on a CT scan image. So the T1 weighted image in an unmyelinated white matter mimics like a CT scan image. This becomes slightly different in a myelinated white matter. So if you see, this is the myelinated white matter. When the white matter becomes bright, the fluid remains dark. But since you are all neonatologists predominantly, you will unlikely to see a myelinated white matter. So this does not happen till at least 5, 6 or 8 months of age. So let's slightly forget about it. Let's try and concentrate here. This is how a T1 weighted image looks like. This was an axial image. This is just by pure anatomy. And this is a sagittal image. This we can see by anatomy. You can see the brainstem in a sagittal section. You can see cerebellum in a sagittal section. This is just to show you that MR images can be acquired in any plane which we want. We can have an acquisition in sagittal plane, acquisition in coronal plane, acquisition in axial plane, whereas practically speaking, CT scan is acquired only in the axial plane. However, we can actually reconstruct those images in coronal sagittal plane also. So let's see what we have learned on T1 weighted image. Actually, it's predominantly CSF or water which gives a low signal on T1 weighted image. That's what we need to remember. So this is a T1 weighted image in which you can see the bone is black, the gray matter is bright, the white matter is dark. In unmyelinated white matter, the CSF is bright. The basal ganglia slightly appearing bright in the unmyelinated white matter. What's more important on T1 weighted images, if you give MR contrast, like CT scan, when we were giving contrast, it was appearing bright on CT scan, which was a iodinated contrast. On MR also we can use contrast, but it's a different contrast which contains gadolinium. The MR contrast will again appear bright on a T1 weighted image. So when we give contrast, we use a T1 weighted image to look at the bright density of the contrast. Compare this to a T2 weighted image. This is a T2 weighted image of the brain. How do you identify T2 weighted image? In the T2 weighted image, the CSF appears bright or hyper intense. So look at the CSF in the sulcal spaces or in the ventricles, it is appearing bright. By looking at it, you can tell that this is a T2 weighted image because the CSF is bright. Is only the CSF bright? No. Any fluid will appear bright. So if it is CSF, it is fluid, it will appear bright. But if there is a lesion which has cyst, which has got fluid inside it, which has got proteinaceous content besides it, which has got pus inside it, which has got necrotic material inside it, or which has got anything else fluid inside it, it will all appear bright on a T2 weighted image. Okay. Let's see how the white matter appears. The white matter is also appearing bright because remember, unmyelinated white matter contains a lot of fluid. Since the fluid is giving a bright signal, the white matter is also giving us a brighter signal on a T2 weighted image, the unmyelinated white matter, and the gray matter is appearing dark. This is in contrast to a T1 weighted image in which the gray matter was white and the white matter was dark. So this is how a unmyelinated white matter appears on a T2 weighted image. In contrast, this is not the same imaging if you see a myelinated white matter. In myelinated white matter becomes dark on T2 weighted image. We still know that this is T2 because the CSF is appearing bright. So let's forget about this. In an older child, this is how a normal appearance is, but for a neonate and up to few months of age, this is how a normal white brain MRI, a T2 weighted image will look like. By anatomy, we know that this is the putamen, this is the caudate, these are the thalami, these are slightly appearing dark. This is the internal capsule, the posterior limb of internal capsule. Some part of it is dark, which is the myelinated part. Some part of it is bright, which is the unmyelinated part because this is at the term age. This is at the 40 weeks gestational age in which only some part of posterior limb of internal capsule is myelinated and anterolateral thalamus is myelinated at this point of time. So what we see on T2 weighted image, the high signal is seen from CSF as well as from any cystic content. Okay, what is the importance of T2 weighted image? Most of the pathologies appear bright on T2 weighted image. Most of the pathologies. There are some exceptions. We'll look at it, but most of the pathologies appear bright on T2 weighted image. So we use the T2 weighted image to look at the pathological conditions. So this is just to recapitulate. This is how a T1 weighted image looks like. This is how a T2 weighted image looks like. The CSF is dark. The CSF is dark in the sulcal spaces. The CSF is dark. The white matter is dark. The gray matter is bright, hyper intense. In contrast, on the T2 weighted images, the CSF is bright, so the fluid is bright. The white matter is also bright. The gray matter is dark. In a neonatal age group, this is how we recognize T1 from T2 weighted images. Okay. I've already told you there appears myelination over a period of time where this white matter gradually becomes bright on T1 and gradually becomes dark on T2 weighted image. This is a myelination process, but let's not go into detail. And the myelinated white matter appears like this. Okay, let's come to another sequence which we typically use, which is a flare sequence. Okay, flare is one sequence in which this is a mixture of T2 and T1 weighted sequence. So in this is a complex sequence. Let's not go into detail. The CSF appears dark like a T1, but the pathology appears bright like on a T2 weighted image. This sequence actually has practically no use, according to me, in a neonatal age group. So we'll not discuss this. I, in my practice, do not even use or do not even do flare in a neonatal age group because that is a mixture between T1 and T2 and especially in an unmyelinated white matter, that is not a useful image. So we'll not go into the details. But only thing which you need to know is in this, the rest of the pathologies appear like T2, but the CSF appears like T1 weighted image. So this is a complex sequence. This is a flare sequence. Okay. This is a diffusion sequence. This is another sequence which we do. How do you recognize a diffusion sequence? This looks like a shaggy and a dirty type of a sequence in which the CSF appears dark, but you do not see any bony outline. You do not see a good gray-white matter differentiation like a T1 weighted image. The rest of the thing is like a T1 weighted image, but looks like a very poor quality T1 weighted image without a bone. This is the classical diffusion weighted image. Where do we use it? We use it to look for all pathologies which show diffusion restriction. That is a cytotoxic edema. Any pathology will show which is showing cytotoxic edema will show bright areas on diffusion weighted image, and we correspondingly get a ADC map. This is apparent diffusion coefficient map, in which this is nothing but accompanying of a diffusion weighted image. We use both of these together to classify whether it is true diffusion restriction or not. So let's not go into complexity, but we'll just look what is bright on diffusion weighted image, and the ADC map is also corresponding to showing diffusion restriction when we call it as a diffusion restriction pathology. Most common examples which show diffusion restriction is acute infarct because that has a cytotoxic edema. Okay, so this is one example. This was a neonatal MRI, a few months old actually MRI. This was a T2 weighted sequence. Why I know this is T2? Because the fluid is bright and the white matter is bright. There is some abnormal area of hyperintensity in the periventricular white matter here. How do I know this is abnormal? Because the contralateral side is not showing such signal. This is an abnormal signal. In a child with acute left hemiparesis, something which is happening on the right side, I know this is an acute infarct. When I do a diffusion weighted sequence, this is a diffusion sequence as I've told you. This is appearing bright on diffusion and this is appearing dark on a corresponding ADC map. So that means showing acute diffusion restriction. So this is an acute infarct. That's how we use diffusion sequence in a MR sequence to detect acute infarcts. Okay, just one more example of a different type of pathology which we see on MR. I've shown you multiple examples of picking up bleed on CT scan. So that was a teaching point that CT scan is a very good modality to detect bleeds. We often use CT scan as the first modality wherever we are suspecting any bleed. Having said that, MR now can also pick up bleed pretty well. Earlier, MR was not very good to detect bleeds, but now we have better sequences. We can detect bleed as good as CT. I will not say better, but as good as CT, especially if it is acute to subacute bleed, we can pick up as good as CT. However, if there is chronic bleed, a remote bleed, then we all know CT scan will not pick up bleed because bleed appears bright on CT scan in acute to subacute stage only. If it becomes chronic, then the CT scan will not show bleed as hyperdense. Whereas MR can still show bleed on even if it is chronic, which may mean few weeks ago, few months ago, few years ago, all that can be seen on MR. Bleed appears complex on MR. On a T1 weighted sequence, very commonly, the bleed appears bright. So this was a T1 weighted sequence. How do I know this is T1? Even if I'm not seeing at the level of ventricles, I look at sulcal spaces. If the sulcal spaces are appearing dark, that means the fluid is dark. That means I know at a T1 weighted sequence. And on T2, this is the sulcal spaces appearing bright. This is T2. So this is something which is abnormally appearing hyperintense on T1 weighted sequences. This is bleed. This is bleed on T2. And we do some special sequences which are susceptibility weighted sequence or a gradient sequence in which the bleed appears like absolute dark. So you can very clearly visualize something which is abnormally bright on these sequences. These are special sequences which we do to pick up bleeds. So this is one teaching point. In MR, we can detect bleeds by doing special sequences which are known as either gradient sequences or susceptibility weighted sequence. And this is just example to show you that bleeds can be very well picked up on MR on gradient sequences also. Another example, even calcifications can be picked up very well on MR, especially if you do gradient sequences. So both bleed and calcification are very well picked up on CT scan as well as good picked up on MR. However, having said that, since CT scan is easy available, can be done quickly, if we have to just look for calcification or bleed, we can actually go ahead and do a CT scan rather than getting a MR done because of the ease of getting it done. For other pathologies, MR is actually better than CT scan, and we'll show you examples. As I showed you example of a CT angiography, we can similarly do a MR angiography and we can look at the vessels. This is MR venography. You can detect the venous sinuses. This is MR arteriography. You can also detect the arteriogram also. This is ICA, this is MCA, this is ACA. One last example, like in CT scan, we can give contrast in MR also, in which, if you remember, I told you we use T1 weighted sequences in MR for looking at contrast. So this is a T1 weighted sequence. How do I know? The ventricle is appearing dark, but there is some bright areas within the sulcal spaces within the sinuses. So this is the contrast enhanced MRI scan, and this is what I'm trying to show you is on MR contrast also, the lesions appear bright on contrast. So this is one example. This is a plain MR, but if you give contrast, the same lesion which was not easily detected here now is showing very bright areas on MR contrast. So lesions which take up contrast, we want to give contrast. When do you want to give contrast? Either in CT scan or in MRI. In both cases, the principle remains the same. If there is blood-brain barrier breach, something which we have given in the vessel leaks out and shows enhancement. So those areas or those conditions we will give contrast. So we will give contrast anything in which we are suspecting infection, because infection leads to inflammation. Inflammation leads to contrast leaking out, and we can see them. So what all infections we either, even if meningitis or parenchymal infections, encephalitis, empymas, abscesses, or infections, even viral uh, um, or even cysticercus, or cysticercus is of course not commonly seen in neonatal age group, but even bacterial, we would like to give contrast. Okay, one. Secondly, in any inflammation, you do not normally see demyelination in neonatal age group, but even if it is slightly older child, if there is inflammation which we are suspecting, we would like to give contrast. Third, if you're suspecting any tumor, tumors will lead to blood-brain barrier breach, and tumors show enhancement on contrast. So you would like to give contrast when you're suspecting tumors. What else? If you're suspecting any vascular pathology, if you're suspecting arterial pathology, arterial occlusion, venous sinus occlusion, venous thrombosis, or you want to see anatomy of the arteries, you would like to give contrast, because contrast goes into the arteries as well as the veins. And if you want to evaluate them, or venous malformations or arteriovenous malformations, you would like to give contrast. You would therefore not give contrast in which you are not suspecting, or uh, in which contrast is not going to help you. So what are the conditions in which you will not give contrast? Any congenital malformation. Those are structural malformations. You would not want to give contrast because contrast does not leak out into structural malformations. You are just seeing anatomical malformations, so those does not require contrast. You do not want to give contrast when you are just wanting to evaluate bleeds. Bleed may you do not give contrast. You do not want to give contrast when you want or suspicion for calcification. You do not give contrast when you are just suspecting trauma. So those are the conditions you do not want to give contrast. Even for most of the metabolic disorders, even if you're suspecting, you do not want to give contrast. Even for infarcts, you do not want to give contrast unless you want to evaluate subsequently vessel also as a workup for stroke workup. Then you may maybe want to give contrast for better evaluation of vessel, but for looking at stroke, contrast is not required. Sometimes if you have to do a perfusion imaging to look for the penumbra and all, then you want to give contrast because contrast helps to evaluate that. But nowadays we have techniques even without giving contrast where we can evaluate the perfusion imaging of the brain. So those are indications for giving contrast. With this background knowledge, let's look at some various examples of cases which you see in our neonatal practice. So maybe you can write in chat. So this is what CT scan on MR or MRI. This was a few day old child. This is a CT scan image. We see the bones are appearing absolutely bright. So these are the CT scan images. The bones appearing dense. So is this normal or abnormal? Remember, I've told you on the CT scan, the ventricles are dark, the white matter is dark, the gray matter is bright. So this is what is a normal appearance. But we do not expect to see something so bright on a CT scan image, especially if this was a plain CT scan image. So we now know, we've learned with experience that bleed appears bright on CT scan as well as calcification. So wherever you see bright areas in this CT scan image, they are within the ventricles, within the lateral ventricle, right lateral ventricle, within the left lateral ventricle, as well as into the left parenchyma also, and some parenchymal hypodensity also seen. So what is seen here is you see a abnormal parenchymal hyperdensity, which most likely appears bleed and which is extending into the ventricle. So there is intraventricular bleed also. See the right temporal horn, but the left temporal horn is showing bleed. So there is intraventricular bleed as well as bleed in the left temporal lobe parenchyma. So this is intraventricular bleed in this child. This was actually a manifestation of PVHI. So periventricular hemorrhagic infarction with intraventricular bleed also as a marker for hemorrhagic uh, ischemic insult in a preterm neonate. Okay. So CT scan very clearly detect. So teaching point here is if you are detecting or suspecting a hemorrhagic lesion in a neonate, CT scan is a good modality to actually evaluate it. Of course, we commonly do ultrasound as the first modality, which can also detect the bleed, but it is operator dependent. Of course, it is harmless, not involving radiation, but sometimes we do end up getting a CT scan done to detect bleed if you're having any doubts, because in the acute and the subacute stage, bleed appears very easily picked up on CT scan, and that's the modality of choice. Okay. But if there is the bleed in a chronic condition, so let's say you were expecting a bleed now, but you are able to image the child, let's say 3 to 4 weeks down the line, then the CT scan is not going to show you that bleed. The bleed will have become hyperdense or isodense by that time. You will only see sequelae of encephalomyelitic changes. Even on ultrasound, over a period of time, the bleed loses its echogenicity and you just see the sequelae in terms of hypoidence. Then, if you want to know whether a bleed occurred or not, you are not even sure, then the only modality which can pick up a remote bleed or a chronic bleed is actually MRI, because MRI picks up hemosiderin also very well. Hemosiderin is the end stage products of bleed. So this is the example of a MRI to detect the same. This was a T1 weighted image. Why? We know because the ventricle appears dark and the white matter is dark. This is a T2 weighted image because the white matter is white, the ventricle appears bright. On T1 and T2, you can maybe just about see that there is some abnormal hypointensity here. That is some dark areas appearing here within the ventricle here, right? So you may feel that there is some abnormal hypointense signal here, which is slightly appearing bright. I know with the how bleed appears on MR on T1 and T2 weighted image, it appears slightly bright on T1 often and slightly dark on T2. But remember, I told you if you have to detect bleed, then we do special sequences, which are the gradient or the susceptibility weight sequence. This is what we have done here. Now it is very easily seen. You can detect a bleed here. So you can pick up this bleed here. And this is MR now showing you intraventricular bleed, slightly a chronic bleed. And this is again a detection of a hemorrhagic ischemic insult, which we all know is an insult which will occur only when the germinal matrix was present. That means in the preterm neonate. So once you detect this on MR, we can actually tell that this was a preterm neonate which had a hemorrhagic ischemic insult which had occurred. Sometimes you do evaluate the child even at 40 weeks or even beyond in a neonatal period, but the bleed may have occurred intranatally and you can still detect hemosiderin lining the ventricular margin. You can tell that the bleed occurred at that time. So this is another example. T1 weighted image, T2 weighted image. You see some dark area at this is the chordothalamic groove. So you see dark areas at the chordothalamic groove and you do a gradient sequence, you can very easily detect this hypointense area here. So you know that there was a bleed at the subependymal location, germinal matrix. The last one to evaluate is at the chordothalamic groove. So this may have actually occurred at around 33 to 34 weeks of gestational age. We can even tell what was the timing of the insult in terms of the gestational age of this child. Another example, this child was imaged at around 2 months of age. The T1 weighted sequence did not show any significant abnormality, but when we did a gradient sequence, we could see that there was some abnormal hypointensity at the ventricular margin as well as the germinal matrix. This was just showing that there is a old uh, uh, intraventricular hemorrhage which you are seeing. I'm just seeing sequelae of old intraventricular hemorrhage. This again tells me that there was intraventricular hemorrhage which occurred in this child somewhere few weeks ago, at least few weeks ago, maybe a month ago, maybe intranatally only in this particular child. This is just to highlight that MR can pick up chronic bleeds or bleed sequelae very well. Another example, in this you can see these are the T1 weighted sequence, this is the T2. The ventricle is dark, the ventricle is bright, T1 and T2 weighted sequence. Besides the ventricle, can you see any abnormality here? Again, yes, you can see the ventricle is dilated, ventricle is enlarged. So this can be most commonly either hydrocephalus or ex vacuo dilatation. How do you know this is ex vacuo or hydrocephalus? The sulcal spaces are not dilated, so there is no corresponding atrophy of the brain parenchyma to explain the ex vacuo dilatation, but the ventricle is dilated, so this is most likely hydrocephalus. What else you see? You again do a gradient weighted sequence. You can see that there is dark area seen within the ventricles. So this is again bleed in the germinal matrix in the choroid plexus. So this was again a bleed. Again to highlight that you can detect the hemorrhagic insult again in these patients. Another example, the T1 weighted sequence also shows abnormal area of hyperintensity within the ventricles. So this is bleed within the ventricles, and the T2 shows dark area. So this is again bleed within the ventricles. Okay, let's shift gears and let's come to non-hemorrhagic insult. So this is T1, this is T2 weighted sequence. You identify by the ventricles. Any abnormality seen may be subtle abnormal white matter signal seen on T1 weighted image or T2 weighted image. In this case, there was subtle early PVL changes which were seen. These are actually difficult to appreciate, but what is more commonly which we see if there is extensive PVL, as we know by DV's grading over a period of time, they go on to form multiple cysts in the periventricular region. So how do you identify cysts? Cysts appears dark on T1 weighted image because they contain fluid. So when you see cystic changes in the periventricular region, we can very clearly identify cystic encephalomalacia. So this is how periventricular leukomalacia appears in the periventricular region. And we know over a period of time, this cyst will get merged with the white matter will dissolve and this cyst will get merged with the ventricle, leading on to ex vacuo dilatation of the ventricle. That's a classical PVL sequelae which we typically see. This is not a neonatal age group. This is around 6-7 months of age. But this is just I'm trying to show you there is significant white matter paucity. The ventricle margins are slightly dilated. And this is the classical findings of end stage PVL. This would have occurred in the neonatal age group, but the child got imaged at around 6 months of age for the first time when the child presented to the doctor with global developmental delay. These are the classical findings of PVL. And you can see a thin corpus callosum also on the sagittal weighted sequences. Okay. This was a prolonged insult. PVL is basically a watershed type of an insult in a preterm neonate. Sometimes there can be acute profound insult, which is the central type of insult, like an abruptio placentae, which can occur, or profound insult like a cardiac arrest or absolute hypoxic, acute hypoxic insult in which A child, we all know the acute central type of hypoxic insult, if it occurs without giving time, will lead on to changes more in the areas which have high metabolic requirement. So what are those areas? Basal ganglia. If there is time for the body to do auto regulation, then these areas have a preferential blood flow coming towards it and they get protected. You do not show abnormal signal in these areas and the periventricular leukomalacia occurs. But if there is profound insult, acute profound insult without time of auto regulation, then there is abnormal hypoxic insult which occurs predominantly in the basal ganglia or in the thalami. So this is one example. We can identify them very well on MR. This is T1 sequence, this is T2. Look at the CSF. Then this is diffusion. Why I call it diffusion? Because look at the margins. You do not see the bone. You see shaggy margins outside. Just a very poor gray white matter differentiation. This is diffusion. This is ADC. So you see that there is some abnormal area of hyperintensity on the T1 weighted images and some subtle hypointensity on the T2 weighted image, just to show you that we can pick up acute hypoxic ischemic changes even in the central gray pattern on the T1 and T2 weighted images, but very well seen on the diffusion weighted images because there is hypoxic or ischemic insult very well picked up. Then what is the timing of this scan? This was typically done at around 3 to 5 days post insult because this is the best time for you to pick up diffusion restriction. We all know diffusion restriction can occur within minutes to a couple of hours. However, the peak diffusion restriction occurs at 3 to 5 days post insult. Subsequently, after that, it starts to resolve, it starts to get pseudo normalized, and by 7 to 10 days or after 10 days, you will not find any diffusion restriction. So, if you need to pick up diffusion restriction and see as an acute finding, the best time to image is around 3 to 5 days. This is a central pattern. Another example of a central pattern of insult, you can see abnormal signal on T1 and T2 weighted images in the central gray matter. So this is acute profound hypoxic insult in a neonate. So we can detect this also very well on MR. These are the areas which you will not see very well on CT scan, but best seen. You can detect them on ultrasound also if done pretty well, especially in the acute stage, but detect very well or even better on MR, which is the modality of choice to detect them. If you do a follow-up, if you just do the follow-up, you will only see sequelae in terms of volume loss and persistent signal changes. This was a child with 1 year of age, but you are just seeing signal changes in these areas, which had happened at the time of perinatal insult for an acute hypoxic insult, but you can continue to see encephalomalacic changes in these areas. Okay. Another sign which I want you to see on a neonatal imaging age group, which is difficult to recognize, but we use them in radiology, is to look for reversal of myelination or delayed myelination. We all know what are the early myelinated areas. In a term neonate, the myelinated areas are the posterior part of the brainstem, some anterolateral part of the thalami, and posterior limbs of the internal capsules, which get myelinated at 37 weeks of gestational age. So if you are imaging a brain of a child which is, let's say, 38, 39 weeks of gestational age, and you do not see myelination of the posterior limb of the internal capsule, that means there is some hypoxic insult or some insult which has happened, which has not led down to, or there is delayed myelination, or there is reversal of myelination of the posterior limb of internal capsule. By using this subtle sign of absent plaque, that means not showing myelination, we can pick up subtle findings of hypoxic insult in a term neonate. Okay. Sometimes you do not see a central pattern, but you do not see a watershed pattern also. You see abnormal pattern of the cortex also. You see there can be a cortical pattern of a diffuse hypoxic insult. Like you see in this particular case, these are the diffusion weighted sequences. I'm sure by now you must have able to recognize diffusion weighted sequence. No outline, no brain, no bone seen. So these are the diffusion weighted sequence. But you see abnormal hyperintense signal in the gray matter, predominantly in the cortical gray matter, frontal lobes as well as the parietal lobes. This is a cortical pattern of a insult. So you may see a cortical pattern, diffuse cortical pattern of insult. This is a moderate and a prolonged insult, sometimes stadium organ. If there is severe prolonged insult, as we call it as a Uh, this is what? This is a CT scan image. The bone is absolutely appearing bright. The CSF is black. This is a CT scan image. If you see, the white matter is appearing absolutely hyperdense. The basal ganglia is also appearing hyperdense. This is diffuse hypoxic insult, which is happened in this child. There is almost loss of gray white matter differentiation. The sulcal spaces are effaced. The basal ganglia are also not well visualized. Only the thalami are spared in this particular case. And similarly, the same findings when done slightly later on MR. This is T1, this is T2. You can see abnormal areas of cystic changes which have started appearing on MR in the T1 weighted sequence as well as the T2 weighted sequence. This is cystic encephalomalacic changes which has happened in this particular child. This is a cerebral devastation pattern, profound and prolonged insult which has happened in this particular patient. Similarly, another example, this is a slightly older child, maybe 1 or 2 months of age, but you see again multiple cystic encephalomalacic changes. You see cystic, why I'm calling it cystic? Because there are fluid density areas which are seen in the white matter on this T2 weighted sequence. These are the T1 weighted sequence, these are the T2 weighted sequences. This is fluid containing signal here, and even the gray white matter is diffusely showing abnormal signal here. I'm sure you've seen multiple normal scans now, but this is abnormal gray white matter as well as cystic changes here. These are the diffuse cystic changes. This can happen secondary to cystic encephalomalacia, secondary to a diffuse hypoxic insult also. But this, if let's say the child was normal at the time of birth, absolutely normal, but then showed regression of milestones starting from 3 to 4 days onwards with a very progressive and a rapidly deteriorating course, and you get a imaging done. This is what you see. Then what is the pattern which you commonly see? You see this as a condition of sulfite oxidase deficiency. This was a proven case of sulfite oxidase deficiency, and you see abnormal areas which are almost like mimicking a cystic encephalomalacia. Can we differentiate on MRI? It is very difficult to differentiate. There are subtle signs which have been described, but on practical purposes, in my experience, it is not easy to differentiate. The only clue which we have is based on the history, whether the child was normal at birth and started deteriorating 3 to 5 day onwards, or the child had an abnormal Apgar score or abnormal presentation at birth only. That will help us to differentiate a cystic encephalomalacia due to a hypoxic perinatal insult vis-a-vis a sulfite oxidase deficiency type of a pattern. Okay, let's see another common pathology. Not very common, but something which we do see in a neonatal age group. A child, this was a T1 weighted image, this is a T2 weighted image. Look at the ventricles, these are dark T1 weighted image, ventricle which is bright T2 weighted image. So on a T1 weighted image, you are seeing areas which are absolutely bright. I have shown you earlier, if you remember, if this is a plain scan, not a contrast scan, areas which are appearing bright on T1 weighted image most commonly is bleed. So you are having a large area of bleed in the parenchyma. You see bleed in the left frontal lobe. You see bleed in the sulcal spaces also. This is a bleed on the T2 weighted image. You see a lot of mass effect and edema, and there is midline shift over the ventricle. So large area of bleed in the left frontal lobe. You also see some abnormal area of abnormal signal in the venous sinus also. So combining the two, if I tell you this child presented with acute altered sensorium, the child had dehydration before that and shows features of raised ICP. By seeing these images, we know that the child most likely has had actually a venous sinus thrombosis, and this is a large parenchymal bleed, a venous hemorrhagic infarct which had occurred. Again, when we're talking about bleed, if you remember, I told you we do special sequences, which are the susceptibility weighted sequence, and we can very clearly detect the bleed in this particular case here. In this particular case, since we were suspecting a venous sinus thrombosis, we went ahead and did a contrast MR venogram, and in this case, we saw that the superior sagittal sinus, the straight sinus, the left transverse sinus, and the sigmoid sinus showed complete thrombosis. So this was a case of venous thrombosis with hemorrhagic venous infarct in a neonatal age group child. So this was just to show you we can detect bleed as well as detect the complications of venous sinus thrombosis very well on MRI. Okay, let's see at this example. This is CT scan or MRI. This is CT scan. CT scan shows bone to be absolutely bright and the ventricles to be dark. See, this is the CT scan image. This is the MRI T1 weighted image. Both of them very easily mimic each other and almost appear like the same. But you need to differentiate that this is MR. Okay. On the CT scan, you can see subtle areas of hyperdensity within the thalami. So hyperdensity I showed you, which was like bleed. There is some again bleed in the along the sulcal spaces here or bleed along the left transverse sinus here. This bleed normally appears brighter than this, but let's say if I tell you this was done around 10 to 15 days after the acute episode in the child, so this is how the bleed starts to become isodense over a period of time. But if you do MR, you can continue to see bleed even at this time, and if you do T2 weighted images, you can continue to see bleed very well. So this is one teaching point I'm trying to tell you. If you want to detect bleed after, let's say, 13, 14 days, 15 days, 21 days, then MR is a better modality to detect bleed compared to CT scan because MR will still continue to show you different signal intensity from the bleed. And this was the case of, again, venous sinus thrombosis. In this case, deep venous was also involved. So there was hemorrhagic venous infarct in the um, deep gray matter also. Okay. Let's show you some other examples. Okay, this was a child again presented with acute encephalopathy, a preterm neonate which was born. Uh, Age is given here, so I've not given you the age, but it is a neonatal age group done with encephalopathy. Okay, what abnormality do you see here? These are the T2 weighted images. These are the diffusion weighted images. On the T2 weighted image, you do see some area of abnormal signal intensity, bright signal, especially in the parieto-occipital area. You see the frontal areas. This is what a normal T2 weighted white matter looks like, but subtle findings, but you can see, pick them up here that this appears slightly bright. Okay, if you're not able to pick up, I'll give it to you. These are difficult, but when you have done diffusion very well, you can see that there is abnormal diffusion restriction in the parieto-occipital white matter and some part of the perineum of the corpus callosum. So there is some insult at the parieto-occipital cortex as well as the white matter. Can anyone tell me in the chat box what is the most likely? This is a preterm neonate with acute encephalopathic features. Anyone wants to comment in the chat? Okay, no problem. These are the classical areas of hypoxic, not hypoxic, hypoglycemic insult, especially in a preterm neonate. These are the areas, the parieto-occipital areas are the most commonly involved areas in a hypoglycemic insult, and that's what we can detect them on MR images also. And this is the sequelae. Same child, when the imaging was done at 2 years of age, these it was done at the time of acute insult. These are the sequelae encephalomyelitic changes we continue to see at these areas. So even by seeing at these areas, we know that this child is showing a sequelae of a hypoglycemic insult, and this was at the time of the acute insult. Okay. Another common condition which we see in a neonatal age group, these are the T1 weighted sequence. These are the T2 weighted sequence. The ventricle is bright, the ventricle is dark. Subtle findings seen, but we correlate with your history which you provide us and the imaging findings. We see some abnormal areas of hyperintensity on T2 weighted image in the region of the globus pallidi. So can anyone tell me in the chat box what it could be? What history would the child have? This is just a 2-month-old child which we are imaging. No one is writing in the chat box anything, I think, or I'm not able to see.
Actually, they are writing in the Q&A.
Okay, in the Q&A, no problem. So if I tell you, and of course you guys know pretty commonly, this is the most common area of abnormality which we see in cases of NNJ, neonatal jaundice or bilirubin induced changes. These are the most common areas, the globus pallidi, which show changes. So if there was significant hyperbilirubinemia, and if you happen to image these children later on, let's say 1 month, 2 months, 4 months, 6 months, these are the common findings which you see any abnormality in the, especially in the area of the globus pallidi. These are the most common areas which we typically see as involved. Okay, this is another patient presenting with acute encephalopathy again. What is the abnormality which you see? These are the T2 weighted sequences. Again, why do I call it T2? The ventricles appear bright, the white matter is bright. What else you can see abnormal here is, maybe some of you can pick up, actually, sorry, there are abnormal signal changes in the thalami, in the brainstem, in the cerebellum, especially the posterior brainstem, as well as the posterior limb of internal capsule. Maybe experienced, some of you who are very well experienced will be able to pick up better, but subtle findings, even if you do not pick up, no issues. This was a child, the age is somewhere written here, 19 days, 19 days old child. But what are these sequences? And these very well pick up the findings here. These are the diffusion weighted sequences, and they very well pick up abnormal signal in these areas, which are I was trying to show you on T2. Even if you're not able to pick up on T2, I'm sure you can pick up on diffusion. These are abnormally appearing hyperintense diffusion. So abnormal areas of hyperintensity in the posterior brainstem, the cerebellum, the thalami, the posterior limb of internal capsule, the posterior limb of internal white matter, acute encephalopathy, 19 days old child. Is anyone answering? What do you think this child has? Okay, something to which you can detect by clinical examination or by even smelling something. Anyone wants to give answer? No, not HI. These are not the common areas for HI. Brainstem is not a very common area for HI. Right. So Rame has given the right answer. These are the classical findings which you see in maple syrup urine disease. These are the common areas which get involved. The areas which are the earliest myelination areas, they are the areas which show acute myelolytic edema, and you see them as bright on diffusion weighted areas. So if you are clinically suspecting, or even if you are not, but if you get an imaging done as a radiologist, we can, by looking at the images, we can actually make a diagnosis of maple syrup urine disease. The classical findings are these ones which you can typically see. This is one not very common, but typical neonatal encephalopathy mimicking a HI encephalopathy. Another patient, another example, this was a 28-day-old child in which we had done imaging. Some of you who have gone expert by now would realize that there is some abnormal area of hyperintense signal changes in the parieto-occipital white matter as well as the gray matter. How do you recognize this is abnormal white matter? Look at the frontal areas. This is how a normal white matter and a normal gray white matter differentiation looks like. But the white matter here, especially in the parieto-occipital areas or even in the perinsular region, is appearing abnormally bright, swollen appearance. The gray matter is quite thinned out, and there is abnormal white matter edema as well as swollen appearance in the parieto-occipital gray matter as well as the white matter. This was again actually a acute neurometabolic disorder, acute metabolic encephalopathy. There was underlying metabolic disorder which was seen in this child. I'm not going into detail, but what you just need to identify and pick up is that there are some abnormal white matter signal changes which are present in this particular case, especially in the parieto-occipital white matter, and that's how you can differentiate and detect metabolic encephalopathy also. Okay. Let's look at some other examples. These are what? MR or CT scan? These are the CT scan images. Again, the bone is appearing absolutely bright on the CT scan. Any abnormality which you see, is this contrast CT scan or this plain CT scan? You see abnormal vessels here or some abnormal hyperintensity here. This is contrast. What you see is the ventricles are dilated. So there is hydrocephalus. CT scan is very good to detect ventricles because CT scan is good to detect fluid, ventricle size, shape, abnormality. If you want to detect, CT scan is good enough. Of course, ultrasound is very good. You can do it on the bedside. You can do it yourself without any radiation, and you can detect hydrocephalus. But if you want to see other complications, you can just do a CT scan, because CT scan very well can detect the hydrocephalus, volume loss, or mass effect on the ventricles. So in this case, the ventricles are dilated, but what is also abnormal is there is some abnormal hyperdensity along the margins of the ventricle. If I tell you this was a contrast CT which was done, so you can see that there is abnormal enhancement at the margins of the ventricles. So this is the what? This is inflammation of the ventricles, and this is classical ventriculitis. So this is another common neonatal complication which we see secondary to meningitis also, or secondary to abscess, which can rupture into the ventricles and can lead to ventriculitis. Another example, this was a CT scan done, I think, okay, 1.5-month-old child. So this is a contrast CT scan. You can see contrast density in the sinuses, in the veins also. But you see what you see, as I had shown you earlier, some abnormal ring enhancing lesion in the brain parenchyma. So this was a child who presented with febrile encephalopathy, acute altered sensorium, and if you do a CT scan, you see a large area in which the central part does not enhance, but the peripheral rim enhances. So one of the ring enhancing lesions in a child with these features which I've told you, in which you are suspecting an infection, this is a classical abscess. So you see edema around the abscess and you see ring enhancing lesion. This was a abscess. Now another example, these are the MR sequences. These are the T2 weighted sequences. The fluid is bright. These are the T1 weighted sequences in which the fluid is dark, but you see some abnormal areas of hyperintensity here. This is a contrast enhanced T1 weighted sequence, not a plain, because you see abnormal vessels here. And moreover, we have written CE big. This is contrast enhanced. What do you see here? You see a rim rounded hypointense lesion, central hyperintensity, peripheral hypointense rim, and on giving contrast, you see only the wall is showing enhancement. The central area is not showing enhancement. It is showing necrosis. So what is the diagnosis here? This is again abscess, peripheral rim enhancement, central bright core. This is classical abscess on T1 and T2 weighted MR images also. Another example, again, this is a CT scan. I am flipping between CT and MRI just for your eyes to recognize CT and MRI together. This is bone which is appearing bright, CT scan. This is contrast enhanced because I can see contrast within the vascular structures, within the veins, within the venous sinuses. I see multiple ring type enhancing structures in the parenchyma with hypodense edema around it. This was actually a case of neonatal candidiasis. These were multiple candidiasis, multiple candida abscesses, which was seen, proven cases actually. And this was a 2-month-old child in this particular. Okay. Another example, a CT scan, which is contrast enhanced because you can see contrast density here. But what you see is there is abnormal fluid type of a lesion, which is seen. This is ventricle, but this is not seen in the parenchyma. This is seen extra parenchymal. And there is some abnormal enhancement at the margin of this fluid containing structure. So this is peripheral enhancement and fluid in the extra-axial space. So this is a classical empyema. You see abnormal enhancement at the periphery and you see fluid density, or in this case, this was actually a pus. So this was a classical empyema, a complication of neonatal meningitis. Another example, in this case, this was MRI. You see that there is some abnormal prominent sulcal spaces. So there is atrophy. The ventricles are slightly dilated. This is the T2 weighted sequence. And in this particular area, you see a large subdural collection, which you see this is appearing bright on T2 weighted image. And when you do a contrast enhanced T1 weighted image, you see the periphery of it is actually showing enhancement. This is appearing bright, so this is showing enhancement. So this was again empyema, subdural empyema in this child. This was MR, this is CT scan. This is a different patient. This is a different patient. You can diagnose empyema on MR also. So another example in this is a MR image. This is the T1 weighted image. This is a T2 weighted image. You can see the ventricle is dark, ventricle is bright. But what else do you see? The ventricle is appearing dilated. There is ventriculomegaly. The lateral ventricles are dilated. The third ventricle is dilated. If you do a sagittal section, you see the aqueduct is showing narrowing at the lower part. You can do a special sequence also to see that the aqueduct can show a small adhesion at the lower part. So this is a classical aqueductal stenosis leading on to a hydrocephalus, which is involving only the aqueduct, the third ventricle and the lateral ventricle, whereas the fourth ventricle is completely collapsed. So this is the obstructive type of hydrocephalus due to aqueductal stenosis in this particular neonatal child. Okay. Let's see some other example, a different patient. Okay. In this, these are the serial T2 weighted images of MR. Why T2? The ventricle is bright. Can anyone tell me what is the abnormality which I have shown you here? The white matter looks okay. The gray matter looks okay, but there is some abnormality here which I have shown you with, and I've marked with the arrows here. What abnormality do you see here? Please, can anyone write any answers either in the question and answer or? Okay, great. Absent corpus callosum, excellent. I do not see a corpus callosum here. Brilliant pickup. What else do you see? What else is this? Besides corpus callosum, what is this? And what is this happening here? Great. The answer given by Dr. Sanjay Wazir is absolutely fine. This is classical holoprosencephaly. It's not just the corpus callosum is not visualized here. You see that there is no interhemispheric fissure. There is no septum pellucidum. The two ventricles are communicating with each other. If you go up, the two hemispheres are communicating with each other. So this is a classical holoprosencephaly. Lower down, even the thalami are actually communicating and joining with each other. So this is holoprosencephaly. This was again a couple of month old child only, and you can detect congenital anomalies also very well on MR if you're suspecting it. Would you like to give contrast here? No. Remember, I told you contrast is not usually required for congenital malformations. You can detect them very well on either plain CT or MR also. Okay. Let's look at this example. Another example showing you holoprosencephaly, but in this case it was CT. You see the thalami are fused, the frontal lobe is fused, the ventricles are also fused. You do not see the corpus callosum also. This was again example of a holoprosencephaly, and this was a few-day-old child. So with this, I will end my talk by my teaching point for today is have a systematic approach, identify whether it is CT. Of course, you know whether it is CT or MR, but sometimes imaging comes to you. Identify whether it is CT or MR. You will confuse only the CT with the T1 weighted image, not with the T2 weighted image, because in the T2 weighted image, the ventricles will appear bright. Identify T1, identify T2, look at something which is abnormal. CT scan, the best abnormality which you can pick up is bleeds, calcifications. Of course, you can pick up hyperdense areas also, but those are difficult to pick up, especially in a neonatal age group. MR is better for that. Remember, when do you want to use CT scan? When do you want to use MR? MR is better than CT scan for most pathologies, but CT scan is equally good for bleed and for calcification. So if you are thinking for bleed or calcification, can get a CT scan done because it is easier to do, quicker to do. There is some radiation involved, but if you're getting it done 1 odd, 2 odd, does not matter much. If a pathology will require 4 or 5 CT scans, then you definitely have to be judicious and try and use MR if you can get MR to be done. And always, I would actually give this teaching message to my radiology residents or my radiology colleagues. I interpret all CT scans, all MR in discussion with my clinical colleagues because this is how I interpret MR. I want to know what are they suspecting, what is their, rather than just commenting upon my MR diagnosis. Sometimes the MR diagnosis is what we call it Aunt Mini, where I can give a direct diagnosis, but many a times it is a differential which I want to give. But if I have the true clinical perspective given to me, I can give you a proper diagnosis also. I'll be happy to take up any questions if you have. And thank you so much for this patient hearing. I think I exceeded the time a bit, but I wanted to take it slow. Over to you, Dr.
Thank you so much, sir.
Kirti and Dr. Amit.
Thank you so much, sir, for your extensive presentation. We thoroughly enjoyed speaking to you and variety of findings on CT and MRI. There are a couple of questions in the Q&A. The first one is like, if you are not able to do MRI within 2 weeks in a neonate with severe birth asphyxia, then what is the appropriate time to do the MRI?
Okay. So why would you do a
So,
MRI for a
what do you
neonatal?
suggest? Like,
Why would you do an MRI for a neonate for birth asphyxia? You are all neonatologists, but what I have learned from my neonatology colleagues is often the diagnosis is clinical only, right? And you would, whatever therapy you institute at that time itself. Often it is the cooling which is required. You do not want to do a imaging before that. Often you do a cooling which is required, or you take measures to do a symptomatic treatment. But if you are in doubt whether or not there is hypoxia, or in thinking in terms of a alternate diagnosis, then practically speaking, if you ask me, the best time to get a MRI done is between 3 to 5 days of post insult. At that point of time, the MRI will be most sensitive and reasonably specific to pick up hypoxic ischemic insult changes. At that time, T1 will be showing abnormality, T2 will be showing abnormality, spectroscopy will be showing abnormality, diffusion will be showing abnormality, if you want to do all these sequences also. If you lose this window, then over a period of time between 7 to 10 days, the diffusion weighted sequences will not show any abnormality. They will start to normalize, and only findings which will be seen will be on T1 and T2 weighted images. Again, they will also, because of volume loss and becoming chronic, they will start becoming subtle, and you will only see sequelae of those hypoxic insult changes rather than acute changes. So therefore, at that time, it is an experienced person which will be able to pick up those changes. Of course, you are doing MR at that time. Either you are doing it for a alternative diagnosis, you are not able to, you are not sure whether there was a hypoxic insult or not, then because you are not going to treat anymore. Or since you are having an alternative thought in your mind which may require treatment, then you can do at that time also. But if you are sure that it was a hypoxic insult and you just want to do for prognostication, and you want to look for the extent of hypoxic insult, then maybe 1 or 2 months is a good time to do. Then you will see a complete spectrum of the extent of involvement which had happened, and the sequelae which have happened. You can actually do beyond 1 month, 1 month, 2 months. That can be a good time to actually see if it is not going to change man. If you are having any doubt of any alternative diagnosis, then you can do at even 20 days, 1 month, more or less. For hypoxic changes, you will going to be finding the same findings.
yeah, thank you, sir. Then continuing with the HI questions also, there are few questions regarding that by Dr. Sanjay Vade, sir. So one of them is there any difference between the neonatal MRI in HI with who has in babies who have received hypothermia versus those who have not received hypothermia?
So, I would not say a personal experience in this, because you will not have the same child in which you will have a imaging and then hypothermia and then imaging again. But as per the literature, hypothermia is definitely shown to, of course, clinically at least uh, decrease the severity of the hypoxic insult, or at least reduce the severity or delay over a period of time. So even on imaging also, we've articles have shown that there is some amount of less changes which are shown, but it's not that the hypothermia reverses those changes. Um, Not much of a difference on imaging, I would say, but yes, I have whatever articles I have read, I've seen that it does show improvement or decrease in the intensity uh, of the hypoxic insult which has happened, basically. Not much of a change actually.
Then what do you think is the predictive value of early MRI findings for long-term neurodevelopment outcomes? Because most of the patients, basically, we have to prognosticate about them, about the baby.
Yeah, so we can see how much. So let's say if you do a MRI and it shows gross cystic encephalomyelitic changes, you would know, you can actually prognosticate the patient, because you'll know that the chances of the cortical recovery are pretty low. Let's say you see a central pattern of an insult on MRI, in terms of volume loss in the posterior putamen or in the thalami, you can actually predict and tell the sequelae of a child, that that child will have probably dystonia happening in them, or a spasticity happening in them, based on the areas which get involved. So you can prognosticate and predict the pattern of abnormality which the child will have. Those are the things which we typically follow. Or let's say sometimes you have a clinical issue with the child, but the MR is not showing you so much of significant findings in terms of a volume loss, and only mild findings, then you can tell that there will be some, of course, improvement which is expected over a period of time. That's how we typically use MRI. Many a times we actually use MRI, our clinicians, not at the neonatal but at a later age group. They use MRI because that's the first time the child has presented. They use MRI to know, because they may not have proper history during the neonatal period. They want to know whether they can attribute the findings to a neonatal hypoxic insult, or should they think in terms of an alternative diagnosis, which they need to do a workup for that. That's typically often we also use MRI for, even in a later stage.
Yes, sir.
So alternative diagnosis rule out. That's what is more important.
Okay. So there are a couple of questions regarding magnetic resonance spectroscopy. What is its value in cases other than HI? And also can you briefly overview this MR spectroscopy and their interpretation of metabolites, if time permits?
Okay, spectroscopy is nothing but you also use spectroscopy for the metabolic workup also, but for MR procedure, we try to look for the various metabolites in the brain, and we can quantify them also. So by looking at various abnormal peaks, we can try and sometimes detect what is the pathology we are looking for. Most common things which we see are the peaks which are the N-acetyl aspartase, the choline and the creatinine peak, which we detect very well on MR spectroscopy of the brain. In abnormal pathologies, the Na peaks comes down, and in most of the pathologies, if there is hypoxic insult, especially if there is anaerobic breakdown which has occurred, there is increased lactate. So by MR spectroscopy, we can detect lactate. Having said that, it is a non-specific finding, just means that it is in your, especially in your scenario, it is very commonly seen with hypoxic insult that you can detect lactate, and you can predict that there is hypoxia. But it can be seen with other pathologies also, like mitochondrial disorders can show increased lactate. Maybe some other metabolic disorders can also show increased lactate, or lactic acidosis can also, conditions can show increased lactate. So that is non-specific in nature. How we use it in HI is, sometimes spectroscopy can show findings even before a T1 or a T2 weighted sequence can show. Let's say theoretically, if you want to do imaging in the first 24 hours post insult, then spectroscopy may show increased lactate, diffusion may show a diffusion restriction, whereas T1, T2 weighted images flare will not show anything at all. So spectroscopy you can use at that time, because it is sensitive to pick up early changes in terms of detection of increased lactate, to detect hypoxic ischemic encephalopathy. In other disorders besides HIE, you can use spectroscopy to look for abnormal metabolites like creatinine deficiency disorder. If you are clinically suspecting it, or you've done a CSF analysis or a blood analysis, But then non-invasively, MR, when if you do and you do a spectroscopy and you can show a very significantly decreased quantification of the creatinine, it helps you to make a diagnosis of creatinine deficiency disorders. In other disorders like metabolic disorders also, you can, even in MSUD also, you can detect abnormal, I think, amino acids, isoleucine, etc. You can detect them as abnormal metabolites in these disorders. You can also detect non-ketotic hyperglycemia by looking at increased glycine peak at 3.56 ppm. So you need to know at what parts per million the peaks appear. By looking at abnormal peaks in those areas, you can actually make a diagnosis of metabolic disorders also. This is besides using spectroscopy for tumors, besides using spectroscopy for trying to differentiate or maybe diagnose even tuberculomas, which are not very commonly seen in your age groups, again, or even in uh, uh, abscesses also, you can use spectroscopy to detect abnormal peaks also, abnormal amino acids also in for bacterial abscesses also. That's what you can use spectroscopy.
Thank you, sir. And one more question is by Dr. Sanjay Vazi that are you using this basal ganglia thalamic and posterior limb of internal capsule scoring system for prediction?
In my clinical practice, I'm not using actually this score. They have not usually asked me for this, for prediction score.
And with currently available point of care ultrasound machines at most NICUs that we have, there's one question regarding that, whether is the ultrasound sensitive enough to pick the calcifications in a neonate with suspected torch infection, or we always need to do a CT?
So it again depends upon operator confidence and experience. Calcifications can be picked up on ultrasound pretty well. They again appear echogenic, hyperechoic, as would flares appear, especially in early conditions, or as would some other abnormalities also. They are non-specific. Calcifications will typically show some posterior acoustic shadowing. So if you can see a hyperechogenicity with posterior acoustic shadowing on ultrasound, you can reasonably pick up or detect calcifications. Then you do not require a CT scan. But for subtle calcifications, which are not very bright on CT scan, or you are not having experience, then MR, even MR, sorry, CT scan is the way to go. CT scan will pick up calcifications better than ultrasound, definitely, especially subtle calcifications. If it helps you to confirm a diagnosis, CT scan is definitely indicated. MR can also detect calcifications, especially if they are slightly more chunky and gross, but subtle calcifications are often missed on MR, and CT is better than even MR to detect them if it helps you make a diagnosis. In my scenario also, if I've done MR and if I'm having a doubt whether there is calcification or not, I often actually still use CT scan to detect calcifications. Better than ultrasound also. But if it is a dense calcification, ultrasound will definitely pick.
So I think we are done with the questions. Thank you so much, sir, for an very enriching and very exciting talk, because we now understand how we can interpret the findings based on the CT as well as MRI of the neonatal brain. So thank you so much, sir, for
Thank
your
you so much, Dr. Kirti. Thank you.
so
Nice talking to you.
same here. So we can close the session for today. Thank you so much, everyone, for joining.
Thank you. Thank you. Bye.